Hi, everybody. My name is Nick Lyons. I'm an animal health officer based at FAO headquarters in Rome. And welcome to this webinar on the FMD serotype SAT1 with a situation update and recommendations for prevention, preparedness and response in the Near East and West Eurasia regions. So we're covering a breadth of different subjects in this webinar today. So on the screen, we have the agenda. So to start with, we'll have a welcome and introduction from Frederica Mayen from FAO. Then we'll have an update on the serotype SAT1 situation in the Near East and West Eurasia from Antonello Donado from the World Reference Laboratory for Mouth Disease at the Purbright Institute. Then we're going to have two colleagues from the Iraq Veterinary Department presenting on the situation there, followed by some presentations on surveillance and early detection, laboratory diagnosis, emergency preparedness, and then aspects of vaccine procurement. So we've got a lot to get through, so I think we should just proceed. So to start with, I'll hand over to Frederica from the FAO office in Cairo to give a brief welcome and introduction. So Frederica is a senior livestock development officer, like I say, based in Cairo at the FAO regional office for the Near East and North Africa. So Frederica, over to you.
Thank you so much, Nick. And I would hereby like to welcome all the participants to this important webinar. So the cause is that foot and mouth disease, one of the most contagious animal diseases, is of very high importance, and because its capacity to spread across borders and attack a large number of animals is present and is a continuous threat. So the recent detection of a new serotype to the region, serotype SAT1, which has been confirmed in Iraq, has raised the preoccupation of countries touched and also the neighboring countries and neighboring regions as well. So the Near East and Western Eurasia regions are in a state of alert, and we face a situation, and we also do not know yet, as it has not been confirmed, if we have to count with other cases of the same new serotype for the region in Syria or in Lebanon. So we need the whole joint efforts to manage the threat and to face the situation and to be able to control the disease. So today, the Food and Agriculture Organization of the United Nations is hosting this webinar, which has the objectives to give an update on the current situation in the Near East and to provide a recommendation regarding to FMD prevention, preparedness and response, and including also the very important role of biosecurity and vaccination. So we have here experts from the World Reference Laboratory for FMD and from veterinary services for the also from EuFMD, the European Commission for the Control of FMD, and from FAO. And with this, I wish you all a very insightful and successful participation in this webinar. And I hope that our joint efforts will help to control the situation. With this, I give back to Nick, and I thank you all for your participation.
Thank you so much, Frederica. That's really appreciated. So I think what we'll do now is we'll move on to the first presentation. which is will be from Antonello Dinardo from the World Reference Laboratory. Let me just stop sharing my screen and you can take over, Antonello. So Antonello is a senior molecular epidemiologist working at the Vesicular Disease Reference Laboratory Group and the FAO World Reference Laboratory for Foot and Mouth Disease, which is based at the Purbright Institute in the UK. If you have any questions on Antonello's presentation or any other presentations or any other queries about the SAT1 situation, please put them in the Q&A box that you'll see at the bottom of your screen, and then we'll address them either at the end of the presentation or at the end of the session. So Antonello, over to you.
Thanks, Nick. Hope you can see the screen as I can see from my laptop. Good morning, everyone. So what I'm going to cover today with this brief talk is about the situation of SAT1 that we are experiencing now in the Western Asia region, but with a little bit of a overlook on the regional aspect of virus threats, virus movement, and the risk of incursion of exotic viruses to the region. As we all know, we tend to cluster circulation of different viruses, different lineages belonging to different serotypes in 7 different ecological pool of circulation. And these are geographically clustered, and they tend to maintain a specific strain within this pool. However, we are known that there are a lot of movement that's happening between the pool, and there is a lot of risk of movement between pools. And there has been a lot of documentation of this kind of transpool of long distance movement of lineages that we can define as often unpredictable because we don't know when it's going to happen. Most of the time tend to be linked with animal movement as well, trading, and anything that related with that kind of epidemiological factor. Within the pool, of course, we have different kind of serotype within circulating within the pool, and as well different lineages. We always consider that international partnership is essential to share data and to analyze the data to understand how we can define more about this kind of potential unpredictable movement and try to understand much better how we can predict, how we can control better potential risk of incursion. But if we want to focus more on the Western Asia region, that is actually defined by the pool 3 of endemic virus circulation, we tend to define that the pathway of movement of the risk of exotic virus moving into the pool 3 is actually from pool 2, that is defined within the Indian subcontinent, and pool 4, that is defined by the Eastern African region. From the east side to the west, we have different kind of potential risk of pathway of movement from the sub-Indian continent, as I said, but sometimes it's not really a preferred route because there are political barriers, for example. And sometimes there are other kind of way of moving viruses from pool 2 into pool 3, like through the what we define as the ruminant street that is crossing from the east to the west, from Pakistan, Afghanistan to Turkey, and is quite a well-defined route of movement of viruses happening in the region. That is actually linked to the way animals move within the region. But as well, we can define other different kind of route that is happening from the sub-Indian continent as well. From the other side, from the west side, from pool 4, there have been a well-defined route that is happening, for example, from the northern part of Africa, from Egypt into the east, and specifically into Palestine, Israel, and the region surrounding those countries. But as well, there are well-defined rules, well-documented routes that are coming from more of the Horn of Africa, from, for example, Tanzania, and Kenya, and Ethiopia, into the Persian Gulf and up to the Western Asia region. So if we consider this kind of threat, in general, the dominant lineages and the dominant serotypes and dominant lineages that are circulating endemically in the West Asia, Gulf state, and the Middle East, as we define for pool 3, there are mainly three lineages belonging to serotype O, A, and Asia 1. Pan-Asia 2 for serotype O, Iran 5 for serotype A, and Asia 1 mainly the Sindo-8 lineages. I just want to note that for Pan-Asia 2 we are currently redesigning the sublineages and are proposing a new lineages that is the sublineages that is Pan 16. This is actually the lineages that are currently exposing a threat to Europe circulating in Hungary and Slovakia. For example, Iran 5 has been the cases in 2004 that has been after 6 years of not recorded in Turkey, and Asia 1 is sporadically observed within the region. As I said, the main threat of virus movement of exotic lineages is happening from Southeast Asia and East Africa. So if you are thinking about Southeast Asia from pool 2, the main threat at the moment from 2020, 2025 is these lineages that is belonging to the MESA topotypes of serotype O, is the SA 2018, and has been recorded 5 times of introduction into the region. For example, in Oman, in Iran, and as well in the United Arab Emirates. From the other side, the main threat to the region that has been documented in the last 5 years are of serotype O, East Africa 2, East Africa 3 in Oman and Bahrain, and serotype AG1 again in Oman, and 2 different viruses belonging to different SATs serotypes that are endemic in Africa, and SAT1 that we are discussing today, and more recently as well the incursion within the region of SAT2 14 that has been quite widely spread in the region and has been reported in Jordan, Iraq, Turkey, and has been quite creating a lot of problem. These exotic lineages that's coming from East Africa are very well documented during the last 5 years. But this is something that is not really new, because movement of those exotic viruses from East Africa to the east into the Western Asia region has been documented from the beginning of 1970 with SAT1, for example. And so periodically we always seen virus of this region moving into the west, into the Western Asia region. But the problem of today is that is actually we are seeing this kind of movement happening more often than we usually perceived in the past, either because we are observing more, so there is more surveillance going on, or either because something is changing according to factors that affect the movement of the viruses. So if you're thinking about what I was saying before about the SAT2 14 topotype, this is something that has been recently observed in 2022 with the cases observed in Iraq for the first time for a long time, and these were viruses that were most closely related to sequences or to viruses that were recovered from samples that were collected in southwest Ethiopia in 2022. You need to think about that this movement of the 14 topotype of SAT2 is quite a striking event, because this topotype has been detected only on one other previous occasion in Ethiopia in 1991. So it's almost 40 years after the first detection of these topotypes. So question is where this virus is harboring, where is the ecosystem of maintenance, and how this virus have potentially raised in frequency and have the potential of moving out of the East Africa region. I would like to thanks for this specific analysis of this movement of this topotype for the usually collaboration that we had with the reference laboratory network in ANSES, and as well other laboratory in the region of Western Asia for generating samples, for collecting samples and send us samples for generating the data. So, as I said, this is an example of introduction to the topic of SAT1. That is pretty much what we observe in and what we are discussing today. So, SAT1 is not new, has been detected previously in 2023 in Qatar, but after that, there were no further observation of cases of SAT1 topotype in the region, in the Middle East, until the 2025, when new samples, new cases were detected in Bahrain, and samples were submitted to the WRL, and of course SAT1 was detected. The closest, from the phylogenetic or genetics perspective, the closest genetic relative of these viruses that were isolated in Bahrain in 2025 was a recent, well, not really recent, but a previous virus circulating in Tanzania in 2020, so more than 5 years ago. It's important to note that, as I said before, there is not only the potential of single lineages of single serotypes moving out, but from one sample that we received from this batch of samples that were recovered in Bahrain, we find evidence of co-infection with another serotypes. And this is a serotype O, East Africa 2, also originating from East Africa. And this topotype of serotype O was already circulating in the region in Oman, for example, in the previous year. So this is not something new for the region. There are tools for rapidly detecting the potential cases of SAT1, and this will be discussed later by Kees van Mijnen in more specific detail, just to point the fact that these are important tools for rapid detection of and discriminate viruses from this topotype against other potential viruses that are affecting the region. But the first case of Bahrain were later subsequent, let's say, observed by other viruses that were, again, not only observed from Bahrain, but as well observed from Iraq. So these samples were already sent for us in March 2025, this year, and also were, as I said, detected SAT1 topotype 1 circulation in Iraq. But the striking feature of the genetic relationship of viruses detected in Iraq and viruses detected in Bahrain is that these belong to two different clades, as we see from these three on the top right. The clade of Iraq is a little bit different from the clade of Bahrain, so it may point to the potential idea of two different kinds of incursion, two different kinds of introduction into the region, and this might represent a different way of viruses moving into the region. But as well, it's striking to note that those sequences were more than 50% in nucleotic difference from the cases that were detected in Qatar in 2023. This is has highlighted, for example, from these three. These are the sequences from Bahrain and Iraq detected this year, and these are the sequences from Qatar detected in 2023. And this is quite an important evidence to not only point the fact that potentially there are multiple than one kind of signature lineages, genetic signature lineages circulating and potential threat in the region from East Africa, but as well could be even pointing to the fact that there are a lot of way of introducing these viruses from East Africa into the Western Asia. We need to think about that all the animals are naive for the serotypes because they are not endemic in the region. So these lineages have a huge potential for a rapid spread across the livestock population of the region and from between countries as well. And we also know from a very recent report from the HOA, from the WAHIS, that there are outbreak of SAT1 reported in April 2025. We haven't received the samples yet, but we will update according to the genetic relationships of those cases in Kuwait, how they relate with other cases that have been detected in Iraq and Bahrain. We have done a few vaccine antigen matching data for potential understanding the protection of the current vaccine for SAT1 against the cases that has been circulating in the region. One thing that we need to think about that for SAT1 we have limited vaccine available that cover potential infection for this serotype. The only one that we have is SAT1 ARO78 that is provided by Boehringer Ingelheim. And from the initial vaccine matching result, it has been repeated with a new aqueous formulated vaccine provided by BI. The evidence is that although the RVM value are low or on the cutoff range of protection, from the titer, the heterogeneous titer that we identified with the result of the vaccine matching data, there are quite good indication that will be quite a good protection. We more or less say that titer of 1.5 log 10 will be protective. We are about thinking about an mean of 2 point something. So it will indicate that this vaccine have a good potency and potentially provide good protection. But I would like to just say that given the fact that we have limited vaccine available for the serotypes, we have considered the risk of potential rapid spread of these lineages across the region. As I said, just a summary of what I was discussing today during this seminar. The epidemiology of FMD is very dynamic in poultry. We have a lot of potential route of virus of exotic virus incursion into the region from either East Africa in pool 4, on Southern Asia in pool 2, and circulation of different lineages as well impact on the selection of the vaccine that we need to adopt to use for controlling the outbreak. As I mentioned before, the sampling from the field of cases reported from the region is critical to understand not only why, how and why this virus is circulating within the region, and to identify potential route of introduction of those viruses into the region, but as well to understand by vaccine matching data if the vaccine that we are currently using could protect against infection. So if you testing is free of charge, so always tend to say, please send us the sample for us for producing data and understand much better the molecular epidemiology of FMD in the region. Testing evaluation, as I said, is important, and for understanding vaccine matching potential. If you want to have more information, there are a lot of way of having those from our website on the WRL, but as well from the network of reference laboratory for WOHA and FAO. These are the links. Please feel free to go and have a look at them for having much more detail on what is going on in the world about the epidemiology of FMD. And I would like to thank to the collaborating FMD reference laboratory and the field teams for the work of not only for the surveillance, directly surveillance in the field and collecting the sample, but as well for sending us sample for providing you a much better understanding, a much better picture of the global epidemiology of FMD. And thanks.
Thank you so much, Antonello. That's really appreciated. There's a lot of information there, and some questions have come in. But I think for the interest of time, I think if you don't mind hanging around until the end of the webinar, and then we can perhaps come to those questions at the end. So I think now we'll move on to the next presentation, which is from our colleagues in Iraq. Let me just share the screens. Okay, I've just shared my screen, so I think you should be able to see that. So, we have two colleagues from Iraq presenting today. We have Dr. Samir Al-Jabir, who's from the Epidemiology Division in the Veterinary Department in the Iraq Ministry of Agriculture. And we also have Dr. Mazin Al-Kafaji, who's from the Central Veterinary Laboratory. I hope I pronounced your names correctly, but over to you to carry on with the presentation. Thank you.
Hi, everyone. Hi, Nick. Thank you for my presentation. Next, please. I will talk briefly about the epidemiological section for FMD. Next, as we know, for FMD is a contagious disease. It's affected cloven-hoofed animals. In response, Iraqi veterinary authorizations, often supported by international organizations like FAO and WAHA, have implemented the vaccination campaign, improved disease surveillance, and promoted the biosecurity practice. FMD remains a priority for Iraqi public and animals health sectors, given its impact on livestock productively, livelihood, and trade. Next. Country risk mapping objectives, registration locations of governmental veterinary clinics and hospitals in Iraq, collecting data of licensed official and private slaughters for sheep, cattle, and poultry, registration data and location of licensed and unlicensed livestock market, recording the locations of the village and knowing the animals population for each clinic or district in the governorate, and knowledge the location of the village in each clinic as a small epidemiological units has not yet been accomplished. Preparing data for the location of the weight area such as marsh and lakes. Identify a host spot, especially for FMD disease by registration, randomly area, and the unlicensed animals slaughters point that are considered hotspot, and this depends on the cooperation with the livestock department of the Ministry of Agriculture for the purpose of the completing the information, and the slaughterhouse department and the veterinary department for know the hotspots and informal trading and the most inflammable area. Next, please. This slide shows the area where the FMD infections appear between 5th of the January 2025 until to 5th of the April 2025 is distributed in all the Iraqi governorate, except the Kurdistan, the north of Iraq, from Nainawa, Baghdad, Diyala, Najaf, Karbala, Wasat, Diwania, Dhikar, and finally in Basra. Next. This slide shows the table for the total viral disease outbreaks in Nainawa Governorate. It's 2 outbreaks, Baghdad 3 outbreaks, Najaf 1, Basra 2, Babil 1, Diyala 2, and finally Wasat 2. Next. Next, Nick. Disinfected as Virgon S in Iraqi 2024 wide distribution. The Ministry of Agriculture distributed the Virgon S to all the veterinary hospitals and the governorate for use to in spraying and sterilizing the burns to limit the separate of the foot and mouth disease. recognized as the part of the ongoing veterinary health measures to prevent the movement of the infected animals and control disease outbreaks. It's helped to eliminate a wide range of the microbes, including the viruses, bacteria, and fungi. This substance is particularly used in agriculture and veterinary settings to limit the spread of the epidemic disease among the animals. Reporting suspected cases, if the animals show symptoms of the illness, they must immediately report the matter to the relevant veterinary authorization government for the necessary action. Next. Next. This slide talk about the animal movement in Iraqi in 2025 following the FMD. In 2025, Iraqi experienced a widespread outbreak of the food and mouth disease, promoting authorities to take strict measures to limit the spread of the disease, particularly regarding the animal movement. Restrictions. The Iraqi Ministry of Agriculture announced a ban of the movement of live animals, including sheep, goats, cow, and buffalo, from disease-affected area. This area, including the governorate of the Baghdad, Babil, Diyala, Najaf, and Wasat, all the animal gathering place known as the Joba. We are also closed until further notice to curb the spread of the disease. Additions to movement restrictions, several other measures were implemented, including disinfectant of the animal pens, free distribution of the appropriated medications and vaccines, formation of the veterinary teams to monitor suspected cases upon slaughtering outside official slaughterhouse without prior approved from the veterinary authorities is in places. Next. I would like to hand over the discussion to Dr. Mazen from the Iraqi CVL to talk about the examination. Thank you. Thank you very much.
Thank you, Dr. Samer. Good afternoon. Next slide, please. Since August 2024, the Veterinary Department of Iraq has been implementing a vaccination program against foot and mouth diseases to control the diseases and comply with the international obligation after following a 2023 outbreak of the diseases with the SAT2 strain. Approximately 2 million of cattle and buffalo and 9 million of sheep and goat were vaccinated with the quadrivalent vaccine. In November 2024, a booster dose of the vaccine was administered with the same vaccine specification. Next. Vaccine specification is area VAC, a Turk 06, 20 Arian 05, or Turk 5, 2009, Pan Asia 2, Asia 1 Pakistan 03, Sindh, and SAT2 Eritrea 98. Next, please. Outbreak. However, in the late January and early February 2025, an increase in the incidence of FMD was observed despite the vaccination program, particularly in central Iraq and Baghdad, where very clear clinical signs of FMD were observed in animals, particularly buffalo and cows, leading to death in the newborns. Next. Cattle and buffalo show typical FMD clinical signs, including frothing of mouth and ropey salivation and vascular eruption of the buccal mucosal cavity. Next. Next, please. the typical FMD clinical signs observed. Next. Samples received at the laboratories and research department were positive for FMD PAN 3D and PCR, but negative for the FMDV serotyping A or SAT2. Next. To determine the serotype of this disease, the positive samples were tested with lateral flow device antigen and serotypes A or Asia1, SAT2, SAT1, where one of the results indicate the presence of serotype SAT1. Next, please. To confirm the test, the samples were tested with the ELISA FMD antigen detection serotype A or Asia1, C, SAT2, SAT1, and the test result indicates serotype SAT1 and O. Confirmation. Confirmatory tests were conducted in the Parabright laboratories on 24 samples sent through and with the assistance of FAO, which were previously examined in Baghdad Central Laboratories. These samples had positive results for FMD PAN test, as well as FMD antigen serotyping test, AO Asia1, C, SAT1, SAT2. Only one sample was negative for all tests. The test result of the Parabright reference laboratory showed that 10 samples were SAT1, 7 were O, and 7 were unknown or serotype negative. Next. The number of test samples at the Central Veterinary Laboratories and Research Department from January 2025 to April were 400 from all over Iraq. Of these samples, 300 test samples showed positive for FMD PAN by PCR test, and 100 showed negative. The predominant serotype were SAT1 and O. The necessary support was provided by sending the test kit for surgical investigation of the disease's FMD antibody detection and SP, as well as for detection of the virus FMD antigen ELISA kit, and also the diagnostic kit for molecular chain reaction primers and the probe in cooperation with the FAO, EuFMD, and GFT TADS, the Arab Organization of Agriculture and Development, also sent experts to Iraq to review the reality of the diseases and provide advice. Thank you. That's all. Thank you.
Okay, thank you so much, Dr. Samir and Dr. Mazin. That's there's again a lot of information there, I think, to digest, and thank you for sharing all of that. What I'll do is, just for the sake of time, because we've got a lot to get through, I think we'll carry on with the presentations. But if you wouldn't mind hanging around until the end, I'm sure there'll be some questions. Please put all your questions that you have into the Q&A section so we can keep a track of them. If you put them into the chat, then it's harder for us to do so. So I think what we'll do is I'll just move on with the next presentation, which I'm delivering myself. So I'm going to talk just briefly on surveillance and early detection for FMD, with a particular focus on the serotype SAT1 situation in the Near East. So just I don't want to go on about definitions, but it's just important to briefly clarify what surveillance is and what it isn't. So surveillance really is the whole package of activities aimed at ascertaining the health status of a population. So it involves collecting data, analyzing data, disseminating data to inform actions. So this is in contrast to monitoring, which is really just about detecting changes without necessarily action being taken. So surveillance is not limited to just case finding. like I say, it involves that whole package of data collection and analysis to generate meaningful information. So then we have our surveillance objectives, and these are the specific goals that are met when data are collected and analyzed. And this can include, for example, early detection of cases, description of the baseline incidence, estimated impact, measuring trends, evaluating interventions, and also determining the freedom of disease. But of course, the output of surveillance alone does not control disease or protect livelihoods, but it does feed into that broader purpose. And it's important to really clarify what the broader purpose of surveillance is, so that you can effectively engage with your stakeholders when you're telling them why you're doing what you're doing. We don't just do surveillance for the sake of it. It feeds into a bigger picture. So the surveillance objectives that you might have in a particular country will vary depending on the current disease or infection status. So from the context of FMD and SAT1, you might have you might know that you're endemic for a serotype O, but you might believe that you're free of SAT1. But your surveillance objectives will vary depending on the serotype, because this is a new serotype, it's a new situation, so you need to think about surveillance differently. So from a general perspective, if your disease status is unknown, then your surveillance objective might be to describe the baseline incidence and impact. And that's also the case if you're endemic and you don't have any control. It's just getting that understanding of the disease in the country. But if you've got a control program in place, then your surveillance objectives need to adapt to that. And what you're interested in knowing is, well, is the program working? So you might be measuring your changes in incidence, and so that your surveillance objective then changes. But of course, you might still also be detecting cases to facilitate control of the infection as well. However, if you tend to have FMD that's a bit more sporadic, so you don't think you're endemic, but you get sporadic cases, then your surveillance objectives might sort of change their focus. So you're thinking about detecting those cases so you can control them, but also to have early case detection. So having surveillance methods in place that really optimizes the timeliness of your case detection. And if you believe that you're free from disease or infection, then your surveillance objective might be to demonstrate freedom of infection, and as well to detect cases early when they come in. And of course, if you're a country that's confirmed free from disease or infection, then you might have to continue to demonstrate that through your surveillance, as well as pick up cases early when they come in. So we often make the distinction with surveillance between passive and active. So it's just important to kind of understand what we mean by these terms. So for passive surveillance, this is observer initiated. So this relies on individuals to report cases voluntarily. So this might be farmers, it might be vets, it could be hunters, or it could be members of the public. But it's a reactive approach where data are collected based on the disease cases that are reported after the events have occurred. And the effectiveness of your surveillance will be limited by the willingness and ability of observers to actually report those cases. So this is in contrast to active surveillance, which is what we call it investigator initiated. So this is a much more proactive approach where the activities are intentionally designed and initiated by investigators or veterinary services, where you have systematic collection of data through field work or inspections or targeted sampling. And examples of this might be serological surveys or surveys to demonstrate freedom from disease, or maybe doing active clinical inspections in near confirmed outbreak areas, for example. So it's an important concept to just explain, and that's with risk-based surveillance. And this is particularly important when it comes to early detection of cases. So the idea is with risk-based surveillance is that you look for disease or infection where it's most likely to be found. And in order to do that, you have to have some understanding of the risk factors for disease in your particular country or region. And you use that knowledge of the risk factors to determine where you actually look, because this is a much more efficient way of detecting those cases early than with a purely random approach to surveillance. So now just to put this into a bit of context. So for early detection of FMD with a new serotype or even for other diseases as well, effective passive surveillance is really critical. And being initiated by observers, you need very good engagement from stakeholders for an effective passive surveillance system. So that's the case with a traditional passive surveillance when you rely on farmers or field vets to report cases. But the problem is with that is that it can suffer from underreporting or delays. And I think if you're a country that has endemic FMD and you have a new case, a new serotype coming in, then I think that they might just think it's the normal FMD, but it may not be. So the messaging around passive surveillance needs to adapt to the particular context. So this is when we start talking about enhanced passive surveillance. So this addresses these potential limitations of traditional passive surveillance by proactively encouraging and facilitating case reporting. So this might include awareness campaigns or having dedicated and streamlined reporting. So you might have a hotline number, for example, to report cases, just to make it easy for stakeholders to report. Or there might be more proactive incentives to get stakeholders to report diseases. So there could be some sort of subsidy or compensation, or even just providing that assurance that there are allocations, there are resources allocated to responding. So something's going to happen if they report. That can be a big incentive. And actually, just providing the regular feedback as well is something else that can really encourage reporting, because if farmers or whoever report cases and then they hear nothing ever again, that can be a real disincentive for them to report. But it's also important to be realistic about what might be stopping reports coming in. So what are the barriers that may be in place? And can these barriers be removed considering that you really want to get these cases reported? So it's important to be to think about what measures you have in place, what policies, and to think how you can really encourage reporting. But ultimately, with enhanced passive surveillance, the benefits come through improved early detection, better assessment of your disease burden, a more engaged and informed community, and of course, a more cost-effective approach to your surveillance in the country. So passive surveillance can be very effective, but actually sometimes to maximize the efficiency of early detection and case detection, you may need to do some active surveillance as well. So if the risk of FMD is heightened, so for example, you have a new serotype in a neighboring country, then you might want to think about implementing some active surveillance in some high-risk areas. So you need to think about, well, what are your high-risk areas? So examples might be, for example, in markets, if they exist and they're still open, or maybe areas with large numbers of animals or along known trade routes, for example. So for early detection, you should be prioritizing looking for clinical disease. So serosurveys are not something that's appropriate for early detection. And if vaccination is being used, is available and is being used, of course, this can affect the presentation of disease. It might look more mild. So you need to bear that in mind as well if you are vaccinating. But when FMD is confirmed, then there is a bit of a change in the emphasis around your surveillance. So you then want to think more about case detection to facilitate control. So by this, I mean, for doing tracings or doing inspections in surveillance zones around your known infected areas. So those are some things that you might think about doing. But the resources can be very limited to do this, of course, particularly if you do get a lot of report cases that can consume a lot of time a lot of resource and time, but resource. So actually that can really put, it means that you might have to really think about how you prioritize addressing these new reports that come in. So you may not continually go to the same area where you know there's disease, but if there's an area where you thought it was free, then that might be one that you want to prioritize. But in both situations, whether you know you've got FMD or not, biosecurity is critical. You have to make sure these biosecurity measures are taken, even if you, if it's just a suspicion or confirmed. It's important, I think, to show stakeholders, to show farmers that you're serious about FMD and the biosecurity, because ultimately we know that the people can spread the infection if they don't take appropriate biosecurity measures. So surveillance will be picking up your outbreaks, but then of course they need to be investigated, and suspect cases may need to be confirmed just at the epi unit level. So by epi unit, this might be a herd or a village level, but there's much more to outbreak investigation than just collecting samples to confirm disease. It provides a lot of critical information for spread tracing, collecting information about the risk factors, assessing control measures, and also, if you're using vaccination, it may also help investigate any potential failures in the vaccination policy. But all of this information is really critical for informing your disease control policy. So it's really important that this information is being used effectively. So there's a couple of guidelines that have been published that I've got on the screen here that could be used. There's a field manual for outbreak investigation and management, but also there's more recently some practical surveillance guidelines for the progressive control of FMD and other transboundary animal diseases that was published last year by FAO. So just to wrap up, there's something else just to be made aware of, and this is around rumor tracking and media monitoring. So this is something that's getting more and more sort of well known and being done more and more by different veterinary services in different countries, really just to kind of get more information about potential outbreaks that might be happening. And this can be a very effective way of early detecting outbreaks. And of course, there are also lots of tools that can be used to facilitate the reporting of diseases. So there's various different sort of mobile phone apps, and FAO have the MRI, which can be used for real-time disease reporting. And then of course there are global platforms as well. So the MRI that the FAO has can be connected to the global Empress-I platform, but there are other platforms as well. So there's of course the WAHIS with the WOA, the World Organization for Animal Health, and actually the World Reference Laboratory for Foot-and-mouth Disease has a very helpful website that's regularly updated and can provide more information. But if there are any reports that you want to submit to FAO, I've included the email for our global early warning system team on the slide here. So you're always welcome to reach out and share any updates that you might have. So that's all I have to say. I hope that was clear and I wasn't too fast going through all that. But I think now, like I say, for the interest of time, we'll go on to the next presentation. So I'm going to now hand over to, I think it's Case. Over to you, Case.
Thank you very much, Nick. And I will try to stick within 10 minutes. There's a small talk on the laboratory diagnostics. There's a focus on SAT1. Next one, please. Yeah, just to summarize the principles of FMD diagnosis, when we talk about FMD virus-infected animals, we can take all sorts of samples. I will come back to that a little bit more. In the acute phase, I would say, like vesicular samples and lesion material swabs, probing samples, clotted blood samples, and we can investigate that in several ways, by virus isolation, by ELISA, by lateral flow test, by RT-PCR, and they all have their pros and cons, these tests, and they are more or less sensitive, and you can do them very rapidly, or they take a couple of days. And in the later phase, when you have no virological tools available anymore, or not too many anyway, the focus is more on antibodies, and those can be detected by ELISA or by virus neutralization test. Next one. And this is also good to realize that in the early phases of the infection, even the preclinical phase, before you have lesions, you can already detect the virus in the blood and in the milk a couple of days before the first clinical signs. And that can also be a way, and has been done already, to investigate, for example, dangerous contacts, farms surrounding an infected farm, to detect them as early as possible. And then you have, of course, the phase where you can have clinical lesions and good lesion material, which is a couple of days, up to a week maybe. And then after that, a week after infection, the first antibodies will appear, and you can start detecting them. Next one. Well, samples for virological diagnosis. In the presence of lesions, of course, vesicular epithelium or vesicular fluid, or vesicular fluid if you have access to that. And don't forget about heart muscle. There's a picture there of myocarditis cases. Sometimes you have large numbers of neonatal deaths, especially in lambs or in young calves. And then also this material is really good for detecting by antigen ELISA or by PCR. And when you do not have lesions, either because you are too early, it's preclinical, you can, as I said, detect the virus by PCR in the blood, and you can do that in serum. You don't need EDTA blood for that. And in a later phase, you can also take probank samples and test for the virus in oropharyngeal fluids. Next. Well, this is the FMDV genome. Next, please. Yeah, and this is just to point out the variable region, which is used for sequencing. And you have heard the talk of Antonello, where the VP1 sequences are used to make phylogenetic trees and to make molecular epidemiological analysis of the relation between isolates. Next. But the virus is not, all of it is variable. Some parts are more conservative. And here you see the parts, what we call the 5' UTR part and the 3D part, where you see the arrows. And those are used for what we call the pan-FMD PCR. Next. Just an example of a pan-FMD PCR. Next. And this is, well, not a lucky coincidence, I would say, but this was a project done by the World Reference Lab a long time ago. In 2016 already, these reagents became available, and at that time many lineage-specific real-time PCRs were developed to be used within certain pools. And this one was for pool 4 in East Africa, where we have like 4 different serotypes circulating, AO, SAT1, and SAT2, and also different topotypes within serotypes. And there, these primer and probe sets were developed, and the SAT1, topotype 1, that is in the middle of the table, primer and probe set was tested now again for the current SAT1 epidemic, and apparently the primers and probes are still perfectly fitting, no changes in those target sites. So this primer and probe set can be used for specific SAT1 detection. Next. So this is just to illustrate that the SAT1 lineage-specific real-time RT-PCR has been tested and is for completely, theoretically, in vitro, completely acceptable, but it has been tested, of course, also on all the available isolates. And when you look into the table at the right, which is too much, and I cannot use my mouse myself, so I have to guide you a little bit through the table. But what you see here is, in the left column is a number of isolates from Iraq, quite a big number of isolates. Most of them were SAT1, also some of them were type O. Some of them were typed already by antigen ELISA after culture. Some of them were only tested by, were not successful in culture and were tested by real-time PCR. And there you see the CT values in the columns next to the serotype for the 3D FMD PCR, which is one of the PEN FMD PCRs, and for the 5' UTR FMD PCR. In general, the 3D PCR is even more reliable and the CT values are lower. But when you compare the values of the 3D PCR with the columns at the right, for the SAT1, the SAT1 specific, lineage specific PCR, you see that the CT values are more or less equivalent and that they are very, very good. And I cannot go through all the lines of the table, but actually there was 100% correspondence between let's say antigen ELISA results and the PCR results, and also the PEN FMD compared to the SAT1 specific PCR showed very good results. So if you want to use that PCR, you can order the primers and probes yourself, or you can ask for assistance. Further information is shown on the website of the World Reference Lab, as you can see there, and I think we will later on share the PDFs of the presentations. And if you have any feedback on the assay performance, the World Reference Lab really appreciates that sort of feedback. Next. Well, the other test, it was also already mentioned by Dr. Mazin from the CVL, is the Isler Purbright antigen detection ELISA kit, which is based on monoclonals. One monoclonal is coated to the plate, and then that monoclonal will be able to capture a certain serotype of viruses, and then there is a detector monoclonal antibody with conjugate and a color development. And this is a really nice, ready to go ELISA kit. Really works really well. You have seen already some pictures from the CVL in Baghdad. They also used it successfully. You should realize you can use it for vesicular epithelium or vesicular fluid or myocardial suspensions, but not for swabs or blood or milk. It's not sensitive enough for that. It's really much less sensitive than the PCR. And of course, you can, if you have virus isolation facilities, you can also use it to identify, to confirm the serotype of viruses after amplification in cell culture. Next. And this is the layout of the plate, where you have like 10 samples on a plate. You can test from left to right. And in the rows, you see the monoclonal antibodies. And in the first row, you see, for example, for sample 1, you see it is a type O. For sample 2, it is a type Asia 1. And for sample 3, it is type A. We have 2 different monoclonals in that kit. Type C for sample 8, that is just artificial result for now, because we think that type C is extinct. We have not seen it for more than 20 years. And then, of course, a PEN FMD control row. And in the lower wells, the lower rows, you see SAT2 and SAT1. Next one, please. Well, also this test was tested for the samples from Iraq, and also here there were very good results for the SAT1 specific components of the antigen ELISA. The so-called PEN serotypic component of the antigen ELISA, so the PEN FMD monoclonal, is not really PEN FMD. It detects almost all of the, let's say, A, O, C, Asia 1 viruses, but it certainly does not detect all of the SAT1 or SAT2 viruses. It detects only a few of the SAT2 viruses, actually, and most of the SAT1 viruses, but at much lower affinity, I would say. If you would compare in the middle of the table here, you can see the results for epithelial suspension. And the first 5, you see a SAT1 diagnosis, where you have, for example, an OD value of 3.76 for SAT1, and then for the PEN FMD, it's only 0.86. So the affinity of that monoclonal for the SAT viruses is much lower, but that's not a problem as long as you have a good and strong signal for SAT1 and no cross reactions for the other serotypes, you still will have a very good and reliable diagnosis. And again, if you use this kit, please send feedback on assay performance to both ISLR and the World Reference Lab. Next. Well, this was also shown already. I will not guide you through it because the whole picture, because this is two different lateral flow devices. The left one is on Asia 1 and O, and we're talking now about SAT1. So on the right one, you can see that lateral flow device, also developed by the ISLR Institute in collaboration with the University of Turin, can detect SAT2 and SAT1, and also this lateral flow device is available potentially and has been used already in the CVL Baghdad to show that to detect SAT1 in samples. Next. Few words on detection of antibodies. Next. Then you have to realize I have to say a few words again to refresh your memory on structural proteins and non-structural proteins. And you see a picture of the virus and a crystallographic picture of the virus. And actually the building stones of the virus particle, the capsid, are the so-called viral proteins 1 to 4. And that is what we call the structural proteins. And the left part of the genome codes for those structural proteins. But that's not the only machinery of the virus, of course. The virus also needs other things like proteases and polymerases and other enzymes, and that is what we call non-structural proteins. And both of them, after an infection, will be exposed to the immune system, and the immune system will respond with formation of anti-SP antibodies and anti-NSP antibodies. I don't have the time now to talk about NSP serosurveillance studies. Next, please. But just to summarize that for the SP antibodies, they are potentially serotype specific, although there is some cross-reactivity, so you would need separate tests or parallel tests for all the different serotypes. For the NSP, it is group specific, so you only need one NSP ELISA to detect antibodies against the non-structural proteins of all the different serotypes. So that's an advantage of the NSP ELISA. Next. Well, the ISLR Institute also has produced antibody kits against structural proteins for different serotypes, not all of them, but for O, A, Asia 1, SAT2, and also SAT1, fortunately. And a few words about that. Next, please. This is the way you could use those tests. You can use them either as a spot test to test like 90 samples on a plate at a single dilution of 1 in 10. Next, please. You can use it semi-quantitatively, where you use test sera in 2 dilutions, 1 in 10 and 1 in 30. And then you can test up to 45 sera on a plate. Next, please. And you can use it quantitatively, where you have really like a titer estimation. Then you can test 22 sera on a plate, and you test it in 4 different dilutions of serum, like 1 in 10, 1 in 30, 1 in 90, 1 in 270. And the reason why I mention this is that because of the cross-reactivity in areas where you have either multiple serotypes circulating or vaccines being used against multiple serotypes, you should realize that there is the interpretation can be quite difficult, and it's really dangerous to use a spot test only against SAT1 and count all the positives as true positives, because it can easily be that another serotype has induced after vaccination or after infection a small cross-reactive titer against SAT1 in this example. So if you want to do serosurveys for structural protein antibodies, I would always advise to do tests in parallel. For example, SP antibodies type O, SP antibodies SAT1, and SP antibodies SAT2 for the situation in Iraq at the moment, and always use titration and compare the titers and take into account also the NSP antibodies and the vaccination history of the animals. Next, please. Well, this is, of course, a few credits on the EuFMD, the Purbright Institute, the World Reference Lab there, and the Esler Institute, and thank you for your attention. Over to Nick.
Thank you so much, Kees. And actually, I did forget to introduce you properly at the start. So Kees is a senior virologist and consultant working for EuFMD, and so has a lot of experience in laboratory diagnostics of FMD over many years. So now we're going to go to the next presentation, which is from Melissa McLaws. So Melissa's a veterinary epidemiologist working with FAO, and she's co-chair of the foot and mouth disease, the GFTADS foot and mouth disease working group. So over to you, Melissa.
Thanks. Are you seeing my slides properly?
They're not in full screen mode, but I can see them.
Okay, okay, how about now?
Yeah, that's good. Thank you.
Okay. Okay, good morning, good afternoon, good evening, everybody. The focus of my short presentation is going to be about emergency management and biosecurity for this case of an incursion of an exotic serotype. So I'm going to start by reviewing some of the key content that you can find within this manual called Good Emergency Management Practice. And to start with, let's think about what is an animal health emergency. You know, it's an event that causes a major disruption that can often be anticipated or prepared for, but it's difficult to accurately foresee when it's going to occur. And this event is defined in time and space, so it's something that has a start, a beginning, and an end. In the case of FMD, it's a bit particular because FMD, of course, in the Middle East countries is endemic. It's normally happening. But in this case, we have a surge in cases that's perhaps becoming out of control. And this is happening because there's an exotic serotype, in this case, SAT1, and recently we saw SAT2, affecting animals that are naive because of course, FMD, the different serotypes are almost like different diseases in that immunity against one serotype gives no protection against the other serotypes. So within this manual, you'll see that it divides the animal health emergency into 4 phases: peacetime, alert, emergency, and reconstruction. And the countries in the region now are either in the alert phase or in the emergency phase. And there's different types of actions according to the phase that you're in. And you can see them here in this, let's see. In this section, we have prepare, prevent, detect, respond, and recover. So I'm going to go through that a little bit, first about the alert phase and then the emergency phase. But before I go into that, I'd just like to point out that the actions in the emergency should be guided by an emergency response plan, which should be prepared during the peacetime. And it should be prepared for highest priority threats, the ones that are either the most likely or the ones that are going to have the highest impact. And a plan like this requires input from all the major stakeholders, and that's not just the animal health specialists, but also people with, stakeholder in terms of financial support or covering the cost of the emergency and response to the emergency, the legislative experts, political stakeholders, operational stakeholders, and then, of course, the private sector, livestock owners and associations who are going to be highly impacted. Such a plan should be approved at the highest level of government, and it needs to be realistic for the country in terms of the resources that are going to be available for the implementation when it's needed. And the plan shouldn't just sit on the shelf, but it should be tested through regular and realistic simulation exercises. And on the right here, you can see some of the typical chapter headings of what would be in an emergency response plan. And you can find this information in the Annex 5 of that manual that I showed you earlier. So focusing in now on the alert phase. And so actions in this phase include enhanced activities with a special attention on preparation, prevention, and early detection. And so the alert phase is when there's a higher risk level, either due to the situation in neighboring countries or because there's the suspicion of an event that hasn't been confirmed yet. And in terms of preparation, at this alert phase, you're going to be wanting to review and enhance your plans and systems. So the plan like the emergency management plan that we just discussed, and systems like communication systems, information management systems. You're going to want to make sure that resources are available to respond when that alert moves into the emergency phase. And another key action in this preparation phase is to do a rapid risk assessment. So you want to assess and identify by which pathways and which sectors might be most susceptible to suffering from the emergency. And in the case of FMD and many other animal diseases, this is often going to be linked to animal movement patterns and trading patterns. Also, during this phase, you're going to be wanting to monitor the situation in the other countries to know what the status of the cases is. Are they still going up? Are they decreasing? Where are they in space? And what are the affected sectors and species? And then it's also a time to raise awareness among stakeholders. So, on FAO, we released an alert a couple of weeks ago about the SAT1. We're having this webinar. We hope that this cascades down and that you use this information also to increase the awareness among stakeholders, all those stakeholders we mentioned earlier, the political ones, the private sector ones, so that they're starting to make their own preparations. And then also in the alert phase, you want to try to prevent the emergency from crossing your borders. So it's still in other countries, so you want to enhance cross-border communication and collaboration to try and get a good understanding about what's going on in the issue, strengthen protections along the border, so reviewing and enhancing your import policies and border controls, strengthening biosecurity measures. And I have a dedicated slide about biosecurity measures, but I want to emphasize that this should not just be on the farm, but throughout the value chain. So for the feed providers, livestock transporters, marketers, waste management, biosecurity needs to be strengthened in all of these areas. And in general, these actions should be based on risk assessment. So a couple of years ago, in conjunction with the SAT2 emergency, we did a regional risk assessment, looking at these different risk pathways here. And so I would encourage you to review this document, and I can put the link in the chat after my presentation, because for each of the countries in the region, we looked at, what are their risks of getting the SAT2, which are going to be very similar to the SAT1 across these different pathways, and also identified some key control measures that should be taken. Also in the alert phase, you're going to want to enhance your surveillance, and Nick has already talked about that. And you might even do some response, some preemptive action to avoid spread. So this might be activating special emergency coordination mechanisms, or pre-positioning resources like securing vaccines in particular might be a relevant activity, and potentially even precautionary movement restrictions could be appropriate in this alert phase. So moving to the emergency phase, once the SAT1 has been detected in your country, then really your focus is threefold. First of all, it's detection. So you want to find infection fast, and that's through surveillance, which was covered by Nick. You want to respond or to eliminate it as quickly as possible. And in some countries, this means stamping out. That's usually not done in endemic countries with FMD, but rather the focus is about the quarantine or isolating infected premises to prevent further spread. And stop it spreading is really about biosecurity and movement controls. So this is what, you know, our colleagues in Iraq were just talking about. This is what they're focusing on, and other countries should be gearing up to be ready to do this as well. So we talk a lot about biosecurity, and biosecurity in this context means actions or procedures that reduce the risk of introduction or spread of disease agents. And this, you know, to do biosecurity really requires people to change their behaviors. They have to believe that there's a risk and that it's worth devoting time and resources to control that risk. We talk about 3 key principles of biosecurity. First of all, we have segregation, which is preventing the contamination. So it's keeping healthy animals away from the virus, and it requires a barrier, which can either be a physical barrier like a fence, a temporal barrier. So for example, making sure that there's time between visits or a gap between days that markets are open, or a procedural barrier like changing footwear. And this is the most effective measure of biosecurity. And this, in any biosecurity protocol, you should have at least one type of segregation measure. The second principle of biosecurity is about cleaning. And this means to remove all visible dirt, which takes some effort. But this is the second most effective measure. And then the third one is disinfection. And so we saw in the presentation from Iraq that they're using Virkon as a disinfectant, and that is an effective disinfectant against FMD, but it needs to be used in the correct concentration and for the correct contact time. But the most important thing, I think, is that the effectiveness of disinfection really relies on cleaning. So the virus can hide in organic matter, and if the disinfectant doesn't directly contact that virus, it's not going to be effective. The virus is still going to be there. So disinfection is the least reliable biosecurity measure. It's kind of a mop. After you've done the cleaning, you've done the segregation. And just one other thing to highlight about biosecurity is that, you know, a lot of people in this webinar are going to be animal health professionals involved with the response, and that there's a real risk through veterinary visits, inspections and whatnot, that fomite transmission or transmission of the virus through people. So it's important that we as veterinarians lead by example, observe biosecurity properly, because if we don't do it ourselves, it's awfully difficult to persuade others to do it. And again, back to our 4 phases, biosecurity is always important, not just during an emergency. So to look at strengthening biosecurity within a sector or a country, FAO has developed a progressive management pathway for terrestrial animal biosecurity, which takes a co-creation approach working with stakeholders. And I would encourage you to check out these materials and to join a community of practice that we have. You can scan this QR code that gives you more information and discussion, really dedicated just to biosecurity. Another key aspect at this point, while the vaccine might not be available for the SAT1, is about movement restrictions and safe trade. And the key here is really to make sure that only healthy animals that you know are free of FMD should be allowed to move. And this is absolutely critical to prevent introduction into new countries and to reduce the spread within infected countries. These movement restrictions have to be covered by legislation, and they have to be complied with. And for that, stakeholders need to understand the need and the benefit for these movement restrictions. They're most effective when, you know, that they're realistic. They have the minimal impact on the animal owners. Ideally, they have a limited duration, then they're more likely to be supported. And similarly, for trade, safe trade between countries, The sanitary measures that are implemented need to be feasible and realistic, because they're only going to be effective if there's compliance with those measures. So these are, some thoughts as you're developing policies and preparing for emergencies like SAT1. So in conclusion, countries in West Eurasia and Middle East are either in the alert or emergency phase for SAT1. We'd encourage you to develop evidence-based response activities, preparation activities based on data. Communication is key between countries, between stakeholders, and the pillars of the prevention response are biosecurity, movement restrictions, and safe trade. And just before I go, I want to highlight that we have a new hub available. We call it the PCP FMD hub. It's on the Virtual Learning Center and you can access it. You have to log in. You can find the page on this QR code. And here we've collated all of the resources about FMD. We have a section on vaccines and vaccination. We have a section on epidemiology and economics. We have a section on sampling and laboratory. We're going to post a link to this webinar here. So please check this out. We also have surveillance information, so you can keep abreast of what's going on in FMD in the world. So please join this hub and let us know your feedback. And with that, I really am finished. So thanks for listening.
Thanks, Melissa. Much appreciated. So, last but not least, we'll go to our last speaker, which is Artem Metlin. So Artem is an animal health officer and interim cluster lead for reference centers, laboratory capacity development, and vaccines at FAO, based here at headquarters. So Artem, over to you.
Thank you, Nick. I believe you can see my screen, right?
Yeah, we can see it. It's not on full screen, but we can see it.
Well, I changed it to full screen now.
There we are. Perfect.
Yeah. So, colleagues, the current list of FMD vaccine manufacturers, as compiled by FAO and WAH, is available here in the on the slide, so you can use it. But I must say that the global production capacity for SAT1 vaccines are currently limited. One of the main reasons is that SAT1 strains have shown limited circulation in recent decades, leading to low demand. Second, as a result, many manufacturers have discontinued production, and those that still hold SAT1 strains often rely on outdated strains. Unfortunately, matching data for these strains is often missing, making it hard to confirm whether the vaccines still offer effective protection against today's field viruses or not. Another major issue is the limited sharing of recent SAT1 field isolates. This is particularly due to biosafety and biosecurity concerns, as sharing live viruses materials requires strict protocols and high containment facilities. To address these issues, we must involve FAO, WAH reference centers and ensure that strain selection, testing, and vaccine development is done through coordinated international collaboration. Solving these issues requires both technical and policy-level coordination to ensure that effective SAT1 vaccines are available when needed, particularly in regions at risk of FMD outbreaks involving this serotype. Building on the previous slide, once we address the issue of sharing current SAT1 field strains, the next step is to move into vaccine development and production. The process starts with the adaptation of the virus to cell culture, which is essential for vaccine manufacturing. Not all field strains grow easily in production systems, so selecting and adapting a suitable strain is a key early step. Then comes strain characterization, a critical phase where we assess the virus from multiple angles. Biologically, to understand how the virus behaves in the lab and in animals. Antigenically, to ensure that the strain provides effective immune protection and has good matching results. And molecularly, using genome sequencing to track strain identity and variability. Once a suitable and well-characterized strain is selected, it can move into vaccine production and quality control. This includes ensuring that the vaccine meets international standards for safety, potency, purity, and stability. Finally, the vaccine must go through the registration and licensing process in the country of origin. This can be a lengthy step, but it is necessary to allow the vaccine to be legally used and distributed, both nationally and potentially through the international procurement mechanisms. And finally, after a vaccine is developed and produced using current SAT1 strains, the final and often most critical step is getting that vaccine into the field quickly and effectively during the outbreak. However, one major bottleneck is vaccine registration in the affected country. This process can take up to 2 years, sometimes longer, especially if the vaccine is produced abroad. In an emergency, this delay can seriously impact response efforts. In some cases, direct procurement can be arranged, particularly if the government authorizes emergency use. But this still requires coordination with the manufacturer and the relevant authorities to make sure that the vaccine can be imported and used legally. To ensure the vaccine are safe and effective, and international quality assurance certificate is typically needed. For Africa, this is often provided by PANVAC, and this is mandatory actually for Africa. In other regions, nationally regulators authorities may issue their own certificate. Once approved, the vaccine must be handled and transported under strict cold chain conditions. Cold chain control and inspection are essential to maintain vaccine integrity, especially in hot climates or remote areas. Finally, the application in the field must be well coordinated, ensuring that animal health teams have clear vaccination plans, proper training, and access to necessary equipment. Thank you. Sorry for a bit fast speaking, but this is to save time.
Thank you so much, Artem, and thank you everybody for the presentations. Yeah, we've covered a huge amount there, and quite a few questions have come in, and I think that what we'll do is we'll just perhaps have time to answer a couple of questions, and then we'll have to call it a day because the time has gone over time. But what we've made a note of all the questions though, so what we'll do is we'll try and sort of send some responses to the questions afterwards. And also some of the panelists have been trying to answer the questions live as well, so it's worth having a look at that. But one of the questions I think that's quite would be quite useful to answer is about the vaccine matching, and there's been a few sort of questions referring to that. And there's one particular question that's referring to some changes in the R1 values that have been presented at some meetings. Antonello, I think it might be good for you to perhaps just clarify those differences.
Yes, the vaccine matching data that I presented and Don King presented even during this week to the general session were updated. So these results were done last Friday. Because BHI provided us a new aqueous formulated vaccine. There's a different one from the sera that we had in the lab, in the WRL lab previously. So we repeated the test with this new formulation, and these show a little bit of increase on protection on both on RVM value and on the heterologous titer, as you've seen from the slide. So yes, this is the difference. So it will mean that this new formulation is a little bit better than the previous one.
Okay, thanks so much, Antonello. I think that clarifies. But there's a couple of questions just about the situation in Iraq. So I don't know, Samir or Mazin, if you're able to reply. There's one question about where you first saw the cases in the country. Did you first see cases in the south or the north of the country?
Excuse me, the first case in the middle of in Baghdad.
Okay. So the first cases were there, and then after that, you started to see it in other parts of the country. Yeah.
Yes, as I said before, as a table, the outbreaks, 3 outbreaks in Baghdad, new 3 outbreaks in Baghdad.
Okay. And there's also another question about what vaccine you've used after the SAT1 has been detected. Has any SAT1 vaccine been used yet in the country?
No, not yet.
Okay.
Because SAT1 not recorded before in Iraq.
Yeah.
You know, we must do vaccine matching before use the vaccine.
Yeah, sure.
Yeah.
Yeah.
Thank you.
Nick, may I ask Dr. Mazin if you have seen SAT1 outbreaks in the Erbil region?
Erbil and Gus. We didn't know about the situation in Kurdistan.
Okay.
Like that.
Okay, thanks. And so there's quite a few questions about vaccination and advice to neighboring countries with regarding whether they should be vaccinating. I mean, I think that some of the information that's been provided today around the vaccine matching and what have you is useful, but of course that's only referring to one vaccine producer, and so there might be other vaccine producers that have SAT1 vaccine, and so for countries that are wanting to vaccinate, they should be making inquiries about that. But we do encourage any countries that are using vaccines. There are studies that are recommended in the FAO WOA post-vaccination monitoring guidelines to sort of do some tests when you buy vaccines. I don't know, Case, do you want to just quickly touch on that?
Yeah, sure, I can do that. Yeah, I think several countries have experience already with what we call small-scale immunogenicity studies, where you vaccinate, for example, 5 animals with a single shot of vaccine, 5 animals with a booster also, and 2 animals as control animals. And the details of all those studies and study types are described in these guidelines that Nick mentioned. And I strongly advise you to consider such studies because they are not very expensive, and it's independent from what you get for information from the vaccine manufacturer. And if I may touch on that, Nick, there was also a question about R1 values, if these are the gold standard. And maybe Antonella wants to add something to that also, but I have tried to answer that one already in the sense that I think it's one piece of information. There is much more into a vaccine, like potency, stability, heterologous titers. They can also reflect high potency. And so even with a rather low R1 value, a vaccine can still do the job when it is when it produces high enough titers. Let's say it like that. Antonello, you want to add something?
No. Yeah, just echoing what you were saying, Keith. So if you want to, because the R1 value is the ratio between heterologous and homologous titers, sometimes you need to look at the heterologous titer to see if there is a good response from the vaccine because of the potency of the vaccine. In fact, one explanation of the difference between the old result of the vaccine matching and the new one will be not only of the new formulation of the vaccine, but as well could be that the latest result that we got is with a more potent vaccine. So in that case, it will indicate that this new potent vaccine will provide a little bit more protection, assurance of more protection for the animal against the infection. So, yeah.
Okay, thank you so much. So I think we're going to have to call it a day, I'm afraid, because we've already gone sort of 10 minutes over time. But I'd just like to say thank you so much to all the speakers for sharing all this new information that I think that people will really appreciate about this concerning situation in the region. What we'll do is the links to the recording will be shared afterwards, and we will endeavour to send some answers to some of these questions that are outstanding in due course. So thanks again, everyone, for dialing in, and thanks to the speakers and panelists. And I hope you have a great rest of the week. Bye bye.
Thank you. Thank you. Bye bye.